I want to thank Dr. Flagg, Professor Tafazul, the whole organizing committee for inviting me to give this talk. So when we look at the cytokines that are involved in JIA, we can see that IL-6 is raised, and it has receptors not just in the synovium, but in the uvea as well, which explains why it has a role in uveitis in JIA. So this is a humanized monoclonal antibody, and the indications are in systemic, polyarticular, as well as in refractory to treatment uveitis, which is chronic anterior uveitis. This is off-label. The first two are actually approved. It's very important for you to just understand this concept that JI is not one single disease. It's a diverse immune-mediated composite disorders that begin before the age of 16 years. They have a common feature, which is arthritis. Although arthritis may not initially be seen in systemic, but other than that, a common feature arthritis that persists for more than 6 weeks, and there is no known cause known, which means that in any patient with polyarthritis, which has had every acute reasons ruled out, including infections, etc., which has been lasting 6 weeks and is negative for other autoimmune conditions, negative for infections, negative for malignancy, that is JIA. And it's the pattern over 6 months which determines the subtype, and it is the most common cause of chronic arthritis in children. Just very briefly, this is the ILR classification in which systemic and polyarticular are associated with the most morbidity, mostly that is what we are going to talk about. So systemic onset accounts for up to 20% of JIA. It is the most serious form, and a mortality rate is up to 4% or even more in some series. And 1/2 to 2/3 will persist as chronic arthritis, with approximately half having significant disability. Please remember that this is a clinical diagnosis of exclusion again. So just like JIA, you need to exclude other autoimmune things, infections, etc. Over here, even more, you need to rule out other causes of fever. So infections, malignancy, like leukemias, lymphomas, Kawasaki disease, and then the autoimmune diseases like SLE. And the patients, before you decide, are diagnosed with systemic onset, should have pan cultures, all imagings done, wherever indicated bone marrow and lymph node biopsy. And in case of a patient presenting with macrophage activation, you may consider genetic testing as well. The S100 proteins can also help distinguish systemic onset from other febrile illnesses, but we do not have this available here. As I said, it has a variable course. It may be monophasic, polycyclic, or persistent. And it is the persistent course, actually, which has the greatest destructive arthritis, even when systemic manifestations have settled. So, joint damage in systemic onset JI can be as destructive as that seen in adult rheumatoid, and damage can occur within 2 years of disease onset. Up to 30% of patients will develop erosions, as well as involvement of the TMJ joint. Most commonly involved small joints, but also the hip. And we have seen that systemic disease, so if you have ongoing fever which is not controlled, there will be ongoing radiographic progression. Therefore, it's extremely important to control this. And so you have systemic onset GI with systemic manifestations which are impacting which have systemic implications like growth retardation. Especially, it has been seen that IGF-1 is decreased in patients with JIA, and also a decrease in bone mass, which leads to an increased risk for fractures, osteoporosis. Mostly, it is most seen in systemic onset as compared to other JIA. Again, most mortality is seen with this subset, and it is mostly due to disease complications like infection, mass, myocarditis, and amyloidosis, which is rare. Amyloid is rare, and I'm only going to talk about macrophage activation here. So this is a young boy with a high spiking fever. I just want to emphasize that if you see this pattern, this is a quotidian pattern, which means that you have a spike during the day and it comes back to normal, and otherwise the patient is well. and he also had pericardial effusion and adenopathy. Then he develops fever, which has become continuous for the last few days. And if you see here, his ESR is 40, his white cell count and platelets are actually normal. And the infectious diffuse and band cultures were negative. But this normal count is actually, this patient was developing mass because the baselines were very, very high. So his ESR was 100, his white cell, he had leukocytosis and a thrombocytosis. In a patient with systemic onset, even if you have normal figures, please watch out for mass. They should have a ferritin done, ferritin done as soon as possible, in addition to other things like TGs, etc. So what happens in mass is that you have a liver dysfunction and coagulopathy with DIC hypotension. You have a bone marrow may show active phagocytosis, but you cannot and you do not rely on a bone marrow for diagnosis. One, you can't always get it done in a sick child, and two, you may miss it. And three, sometimes you can have macrophages seen in bone marrow in a patient who's not showing overt mass, so it's not a 100% correlation. This child responded partially to solumedrol and cyclosporin. Unfortunately, anakinra we have given and it's done very well. It's not available these days, and he did respond to tocilizumab. This is a classification criteria, which is a new classification criteria. It's important again to see the platelets on the left, less than 180, TGs are high, fibrinogen is low. So again, anybody who has a dip in 2 cell lines and in systemic onset GI, if they have normal lab parameters also, please make sure that you don't miss macrophage activation. So this is, classification in GIA, like most other diseases, is basically for research purposes. And more, we now think that even ILR needs to be superseded by other more phenotypically focused classification of the types of GIA. And so Printo has proposed this, in which only thing that you need to remember is that there is a phenotypic difference, that all polyarthritis GIA, which is ANA negative, is actually poly-GI. Even if it starts as oligo, as long as it is ANA negative, there's no psoriasis, so all other polyarticular GI will be poly-GI, and that is the place where you can use actually anti-IL-6 inhibitors. In poly-GI also, we see there's a difference in the growth, and again, impaired growth velocity is reported, although not as much as it is seen in systemic onset. And we know that IL-6 levels have an inverse association between growth velocity. All suggested treatment pathways for GIA, and you can find them from the ACR to the latest, which was NHS England Clinical Policy Statement. They all basically work around with the same drugs. You have synthetic DMARDs, and methotrexate is the core drug that should be started in all children with polyarticular GIA, and in systemic GIA with polyarthritis as well. And then you have IL-6 inhibitors, which are tocilizumab, which are used for both systemic as well as polyarthritis. So we now know that more and more GIA treatment is moving towards the treat-to-target approach, because it's been seen that the window for inducing clinical remission is greatest with early treatment within months of onset of disease. So we've had 2 very good trials that were presented, which is treat-to-target in GIA, early aggressive therapy as well as aggressive combination drug therapy, which used a combo of synthetic DMARDs with biologics, and in these 2 cases, these were anti-TNFs. And it was seen that you achieved better ACR responses with the addition of the anti-TNF and early initiation of treatment. So what we want is, we want our patients to be in disease remission off of medication with acceptable disease control to prevent long-term damage and obviously improve the quality of life. Why is it important for us in Pakistan? We know that we've had revolution of biologic DMRs globally, but some of them, and many of them, in fact, I should say, are available in Pakistan as well. And so initiating early intensive therapy and a treat-to-target approach is possible in our setting as well. When we look at and apply the numbers, we know that we do not actually have prevalence rates in Pakistan, and they vary globally. However, if we just apply those global rates to our population and our young population, the prevalence is anything between 200,000 to 200,000. So 20 lakh children might be out there suffering from juvenile idiopathic arthritis. And so this is a young population that is being set up for disability if they are not diagnosed and treated in time. And we also know that the risk factors for worse outcomes are always delay to diagnosis, poor access, and inadequate special services. And also children living in countries like ours with worse socioeconomic status. We do not have guidelines available as well. So there is a concerted effort within the Asia-Pacific region. We are working on guidelines for low resource income countries within the APLA region, and hopefully we will have something by the end of this year, inshallah. And we also know that patients living in countries with lower GDP like ours had greater disease activity, greater damage, and as you can see, more systemic and polyarticular disease is seen in these low resource income countries. So this is like a stack, high stack against the prospects for children unless we all make an effort. And you know, it's not just systemic onset which is a problem, but without treatment, this polyarticular child came as a young woman who was not diagnosed with GI in time. She was treated with benzyl penicillin. She was put on anti-tuberculous therapy. And by now, you know, she had such bad deformities, I can't even show you the rest of the photographs. And on the right side, another girl came within 6 months. She was on treatment. And as you can see, she's doing so well. So it is extremely important to understand that there are things worse in life than dying, and that is living with disability. And I think it falls to all of us to try and, you know, sort of like work on improving health resources, on improving the expertise of health resources and health professionals and health personnel that are actually seeing these children. And so I commend the effort by University of Clinical Health Sciences as well as that of the faculty of Sheikh Zayed Hospital, and they have our support for basically working on the pediatric rheumatology training program. So these are the current approved pediatric indications for the biologics, and I just want to focus on this. So when you look at Tocilizumab, that is the one biologic that is FDA approved for systemic onset JIA and polyarticular JIA, which I've now told you encompasses a bigger group than the one that was initially, given the ILR classification. So we know that IL-6 levels are elevated. We know that they are correlate with CRP and fever. We also know that they are elevated in patients with poly-JIA, and they correlate with joint damage and markers of inflammation in poly-JIA. And that is the rationale behind why anti-IL-6 inhibitors are so effective in both these sub-classifications. And then those trials that were done, both for looking for efficacy, as well as, efficacy in terms of improvement of swollen and tender joint count and the ability to wean off corticosteroids. It reached, these trials reached their endpoints. But however, you must remember the risk of infection, neutropenia, and abnormalities in liver functions. So you have to make sure that, these patients are screened before and during the infusions. Again, this was extended to 5-year data, and it seemed that the same safety and efficacy results were seen over the 5-year period. Also seen that anti-IL-6 actually helps children to catch up in their growth phase, which is a fantastic thing. And both in systemic onset JIA as well as in poly-JIA. And then, from intravenous Tocilizumab to subcutaneous, both were studied, and the efficacy and safety was comparable. And since subcutaneous is much more easier for children, and so the compliance is also better. Again, safety and efficacy, same thing in polyarticular is also being seen. So to conclude, when we look at what is important is the rates of infection. So we see that the rates of infection were similar for the 2-year period, for the 5-year period, and particularly the risk factor for neutropenia is more when the younger the child and if you're using methotrexate, especially in polyarticular. However, neutropenia was not, the degree of neutropenia was not consistent with the same degree of risk of infection. And the reason for that is that IL-6 actually works on the liver receptors as well. And so you know that leukocytes are also acute phase reactants and neutrophils also. So sometimes because of anti-IL-6 activity, you may have a drop in neutrophils, but not an increased risk of infection somehow. So this was shown, and but of course you need to keep your absolute neutrophil count above 1500 at all times. Again, growth improved with poly-GI as well. I just want to mention that Tocilizumab has been used in chronic anterior uveitis. Chronic anterior uveitis is that uveitis which is seen in the ANA positive subgroup of children, younger age onset. Whether the extent to having more than 4 joints later is not the thing. It is young age of onset, ANA positivity, and primarily initially oligoarticular. And because they are young, they are asymptomatic and they cannot actually perceive that there is a problem with their vision. It's extremely important to screen these children with GI, all children with GI, but particularly this subset with the ANA positive. And in patients who do not respond to therapy, like methotrexate has been used, and of course adalimumab works very well, infliximab works very well. But for refractory uveitis, tocilizumab is indicated. We have used it and it has shown good results. So one word of caution, please remember you're increasing the risk of infections with an anti-IL-6 inhibition, including zoster, tuberculosis, fungal. You can have bone marrow and liver toxicity, which is seen more in anti-IL-6 as compared to anti-TNF. You need to monitor their lipid profile. There may be an increased risk of cancer, but it's not been, there's not enough data. And of course, we know that if you have diverticular disease or there's a risk of diverticular bleeding, and so you need to watch out for that. And there may be a risk of some neurological risk of demyelination. Again, we don't have enough data. Please remember to vaccinate your patients. And live vaccines have to be given before the start of therapy. You must do yearly flu and pneumonia 5 yearly. Inactivated shingles is not available here in Pakistan. It is available abroad, and wherever possible, patients should be vaccinated with that. So the doses are IV, they are available, you can see, and subcutaneous as well. So I just think that, you know, it's very important for us to remember, for each one of us, we have to keep trying our best with our patients, and you know, as much as we can learn, probably look again, and if we are stalled, we must ask other colleagues. Don't forget, for all the trainees, safety comes first. So there is no magic bullet. There's always collateral damage unless you're very, very careful. So the best of therapeutic agents are nothing if you do not use them carefully and intelligently. We have just want to share the Arthritis Care Foundation funded children with you. You know, I'm proud to be part of this foundation where we are trying to help all children and adults who cannot afford expensive treatment or drugs. And some of the activities that I'm here with some of my team, as well as the colleagues in PSR, and we just initially inaugurated last year. Dr. Laura Landowski was visiting from NIH. She's the clinical head of lupus genomics in children at NIH, and we started clinics for children, adolescents, and young children at National Hospital with an inpatient facility. And of course, we are nothing alone. So I want to just give a shout out to my very respected colleagues who are sitting here and invited me, Professor Tafazul, Dr. Flark. Nikhat couldn't make it, so apologies from her. And some of the resource links which are available, these are free resource links, please go visit them. And thank you for your attention.